That's for boys.
No, that's for us. Medicine is separate.
Medicine is not federal.
Yeah. So
But on the food court,
Yeah.
there are people who do not allow girls to pass by.
That's very bad.
But you have your own food court on second floor.
No, we don't have any.
There used to be.
Used to be only food court we have. Except like only one, two.
No, when there was strict separation, segregation,
Yeah.
there used to be few years ago a separate food court for girls.
We never had. We don't have.
So there used to be. So, am I allowed to start? Should we start? Okay, anti-epileptic drugs. As the name indicates, the drugs used for the treatment and prevention of epilepsy. And you know what is epilepsy, don't you? Okay. At the end of this lecture, you should be able to classify anti-epileptic drugs and pharmacology of anti-epileptic drugs, and apart from routine management of epilepsy, we will also discuss few minutes about the management of status epilepticus. I'm sure you know the difference between general seizures and status epilepticus. If not, I will let you know later on. And finally, I will share you with a slide which will show you the drug of choice for various types of epilepsies and the alternative choices. Okay, epilepsy is a condition in which seizures occur. It is associated with episodic high-frequency discharge of impulses by a group of neurons in the brain, hyperexcitation, depolarization. And you can manifest that hyperexcitation or depolarization generalized or in part of the brain by some bodily abnormal movements or unconsciousness. And there are various types of epilepsies depending upon the site involved and the severity involved. What starts as a local abnormal discharge may then spread to other areas of the brain. And as I mentioned, convulsions, spasm, and loss of consciousness. You can see in patients. Now, abnormal electrical activity during and following a seizure can be detected like ECG on EEG. I'm sure you are aware about EEG, electroencephalogram. It's the electrical recording of the electrical activity in the brain by putting electrodes on the skull, like ECG. Okay. Can anybody tell me the difference between, there are two interrelated terms, seizure, rather three, seizure, convulsion, and epilepsy. Can anybody tell the difference? Yes.
Isn't it like seizure just happens like one time, and then when it comes to epilepsy, it's like chronically the person ends up having it constantly?
Very good. So epilepsy is a chronic neurological disorder associated with hyperactivity of the brain or generalized hyperactivity of the brain, leading to manifestation, bodily manifestation, which can be a seizure. Seizure and convulsion are basically the same. Where the seizure is a single event. Now I put it in other words, that epilepsy causes seizures, always causes seizures, but not all seizures are due to epilepsy. Can you figure out the difference between these sentences?
Yes.
So epilepsy is always associated with seizures or convulsion, but seizures can be due to non-epilepsy conditions. like hypoglycemia, electrolyte disorders,
Trauma
emergencies,
as well.
trauma, meningitis, stroke, many things can lead to seizures, but those are short-lived. Once the pathophysiological mechanisms that lead to seizures, if it is corrected, seizures are not. Whereas in epilepsy, there is a chronic neurological disorder that requires long-term or in some cases lifelong treatment. That's epilepsy. Okay? So this is basically, this is disturbing. Is it always like this?
Yes, doctor. It's gonna be a quick side from
Okay. Okay, in that case, look at the last slide. So, the drugs which we are going to discuss today, the title of the lecture is Anti-epileptic drugs. But majority of them are also used to treat convulsions or seizures due to conditions not categorized as epilepsy. So the better term to use would be anti-convulsant or anti-seizure drugs, not anti-epileptic drugs. Did I convey the message? Is it difficult? Because these drugs which we are going to discuss, they are not only useful to treat epilepsy, but all other conditions associated with seizure. So better to use the term anti-seizure or anti-convulsant rather than anti-epileptic. Classification of seizures while talking to students, boys, I found it very confusing because you are not aware, you do not have prior teaching about types of seizures, do you?
No.
Not yet. So I will briefly touch upon. Partial seizures are those which last about half to 1 minute. After secondary, there is no loss of consciousness, convulsions of group of muscles in the body or localized sensory disturbances. Very brief, very oh God. And then there are complex partial. They last about 1 to 2 minutes. Aura often precedes in complex partial. Aura, A-U-R-A. Is this term familiar to you?
Yes.
Aura, who, what is that?
It is something that tells the person that, oh, I'm about to get a seizure.
Okay, so it is a feeling. Okay. Feeling or some special sensory stimulus trigger. So you feel,
You can see or hear.
see, you can hear, you can simulate something. But now it is coming. It is coming. It proceeds, it lasts 1 to 2 minutes. And then the most common are generalized seizures, which some of you might have seen, maybe, sorry to say, but in the family or the relatives or the friends or even the movies, you might have seen generalized tonic-clonic seizures, jerky movements, followed by maybe loss of consciousness, generalized tonic-clonic. Previously, the term was grand mal epilepsy, grand mal or generalized tonic-clonic seizures. And sometimes this type of seizure may be continuous. Generally, it lasts about 1 to 2 minutes. When it continues without any recovery time, then it is called as, the term used is status epilepticus. Status epilepticus. And I have spared a separate slide for the management of status epilepticus. That is emergency situation, potentially fatal or permanent neuronal damage. And then we have absent seizures, very brief, few seconds, less than 30 seconds. While talking to you, I may all of a sudden doze off, completely blank. Generally it is, not very serious issue, But think of a situation in the context if someone is driving, operating a machinery, or on top of the mountain, and then are swimming. For 30 seconds, he is completely blank. He will die. So in that case, although from the outset it seems benign, but can become dangerous depending upon the situation. So this is petit mal or absent seizures. Too much now. And then we have atonic seizures. When the patient becomes unconscious, all muscles are relaxed and patient may fall down. Myoclonic contraction of the muscles of a limb or a whole body, and then leave them. And finally, look at this. This is the model, as I mentioned, status epilepticus. Seizures that are repeated frequently enough that the recovery between attacks does not occur. It seems continuous. Okay. Now what happens is, oh, forget about this slide. Now since epilepsy or seizures are excitatory neurotransmission in the brain, excitatory neurotransmission and inhibitory neurotransmission are in intricate balance with each other. Okay. What are the most important excitatory neurotransmitters? Glutamate and aspartate. Okay. And then we have inhibitory neurotransmission, and most important in the brain are GABA, and the spinal cord, the spinal cord is glycine. Okay. So they are in fine balance depending upon the situation which should overcome. Now in epilepsy, it is always the excitatory neurotransmission, the balance goes in its favor. Or alternatively, either too much excitation or too little inhibitory, which can regulate the excitatory neurotransmission. Too little inhibitory neurotransmission and too high excitatory neurotransmission, that happens in epilepsy. Now the goal of treatment with anti-epileptic drugs is to restore that balance between excitatory and inhibitory neurotransmission. So overall, what will happen? All the drugs which we are going to discuss today, either they inhibit the excitatory neurotransmission or potentiate the inhibitory neurotransmission, or both. Now the channels involved at the ion channels level, now you mentioned that NMDA, I mean the glutamate and the aspartate receptors, they are coupled with what? They are coupled with what? G-protein coupled receptors, and then that eventually leads to opening of calcium channels or sodium channels. And then in case of glycine inhibitory neurotransmission, what is the main channel responsible for the inhibitory neurotransmission associated with gamma chloride? Okay. So in that case, either if we translate these receptors into channels, so we can say reasonably that in excitatory neurotransmission there is the increased opening of either calcium or sodium channels. That leads to depolarization and excitation. Am I correct? And in case of inhibitory neurotransmission, it is mainly chloride channel. The opening of chloride channels will lead to influx of chloride intracellularly, leading to hyperpolarization, and the neurons becomes hyperpolarization. Neurons will go away from the depolarization and hence the excitation. Am I correct? Are you with me?
Yes.
So in that case, at ion channels, this is happening. So all the drugs are either inhibitor of calcium and sodium channels or enhancers of chloride channels. In this way, they will keep the neuron away from excitation. Please interrupt me and ask the question if you do not understand. Okay, let's move to anti-epileptic drugs. I told you the general principles. Anti-epileptic drugs are classified into two main classes. One are classical drugs, although some of them are not used anymore, especially the phenytoin. Even though you do not use them, but you are bound to study those are classical drugs. Classical drugs. And phenytoin, carbamazepine, valproate, ethosuximide, benzodiazepines, barbiturates. These are classical drugs. We have to study them. And then there are newer, like lamotrigine, topiramide, gabapentin, tropicamide, and like that. Out of those, we will study only two drugs. So the formulary for today's lecture is, I will tell you the formulary. Two drugs from the newer drugs, which are lamotrigine and levetiracetam, and all the classical drugs. That's it. I have mentioned here. For exam purposes, you will study two drugs from newer drugs and all the classical drugs. Now we will discuss one by one. Have you heard about phenytoin? I am just teaching you from my memory, otherwise I can't see anything here. It's blank. Phenytoin, forget about this. Here is computer. Phenytoin is the oldest drug, oldest anti-epileptic drugs, invented somewhere in 1930s, the first anti-epileptic drug. It is the inhibitor of voltage-dependent sodium channels. Now, conceptualize, imagine, a drug which inhibits sodium channel, what will it cause? It will cause inhibit the depolarization of the excitable tissue. Now I refresh in your memory with the first lecture in this class. Who took? Local anesthetics, lidocaine, trilocane, bupivacaine. All those are sodium channel blockers. So sodium channel blockers are the voltage-dependent sodium channels, which are the first event in the causing depolarization and eventually leading to excitation of the excitable tissues. And excitable tissues are muscles, neurons. Not only that, but there is one organ, tissue in the body, which has which has sodium channels very close to neural sodium channels. That is why all the local anesthetics, especially the lidocaine, you will see in the triangle, it is one of the top class anti-epileptic drugs you will study in the CBS block this year. Okay. Likewise, phenytoin. Oh, it came back. So phenytoin, similar to lidocaine, it is sodium channel blocker. And by virtue of inhibiting sodium channels, it decreases the excitability of the neuron in the CNS, thereby working as anti-epileptic drug. Now the issue is that phenytoin is, although rarely used now, but very interesting pharmacokinetics. Do you remember first order kinetics and zero order kinetics of drugs? In BOD block, Dana took the lecture. Okay, let me refresh your memory. First order kinetics, when you increase the concentration of a drug, the elimination also. you. Now, first order kinetics and zero order kinetics, when you increase the dose of the drug and hence the concentration of the drug in the plasma, accordingly, the elimination rate of the drug will also accelerate. So, if I make up a definition of first order kinetics, if you remember, there is a constant fraction or proportion of the drug being eliminated per unit of time. Do you remember that? First order kinetics. Now, opposite to that, there is zero order kinetics. It is not dependent upon the concentration, it is a constant amount, not fraction. Constant amount of the drug being eliminated per unit of time. Now what happens, the majority of the clinically relevant drugs which we use in the practice, they follow first order kinetics. So if by chance you have overdose, accordingly the drug will be eliminated in an accelerated way. So most of them are safer. Some drugs they follow zero order kinetics, a slight increase in dose. Since a constant amount is being eliminated, the consequence of increased dose will be accumulation of the drug. Accumulation of the drug means toxicity. So phenytoin is interesting in the nature, its therapeutic range, it follows first order kinetics. Later on, with slight increase in dose, it follows zero order. So that means there are chances of accumulation of the drug and hence the toxicity. So that is why now I took the lecture, if you remember the concept of therapeutic drug monitoring, TDA in POD. There are several drugs like digoxin, like phenytoin, like warfarin, which have narrow therapeutic index. They should operate within a narrow limit. Okay, narrow limit. Beyond that, they may become toxic. So you have to maintain a range of the drugs that you can do. You must monitor. That is, take out the blood sample and see the concentration. If it is higher than the optimum, you decrease the dose. If it is lower than optimum, you increase the dose. A level has to be maintained, which is known as TDM, therapeutic drug monitoring. So in case of phenytoin, look at the slide. It goes as first order kinetics. From here, when you increase the dose, suddenly the curve changes. The trajectory of the curve is changing. The drug is accumulating now. In that case, the therapeutic drug monitoring becomes mandatory, TDM. As I mentioned, it is not used frequently. You will see later on because of the side effects. It can be used in any type of epilepsy. Keep in mind, I will ask you later on, in the bracket it is written except seizures. Just keep in mind. All epilepsies can be used except seizures. What is so in the seizure?
You won't know you're having the seizure, but you just don't pay attention to it.
No, it cannot be used. I mean,
Why it can't be used?
it won't work. It is ineffective. Okay? Because the pathophysiological mechanism of absence seizure is different. I will touch upon this topic later on. Just keep in remember it. It cannot be used. However, it can be used in trigeminal neuralgia, fifth cranial nerve. Have you heard about this term, trigeminal neuralgia? As the name indicates, it is a pain in the trigeminal nerve. Starting from face, it becomes headache, severe pain. So this drug is very effective in trigeminal neuralgia, and it can be used in cardiac arrhythmias, as I mentioned, and status epilepticus, not orally but IV. Now look at the adverse effects. Can you use it for several years or maybe lifelong? Cannot. Now, one side effect which I want you to relate with your PBL case, with your first PBL case. There was first PBL case was about spinal bifida, meningocoele, it was meningocoele, spinal bifida. What was the reason for that? Folate deficiency. Neural crest development is highly dependent upon the optimum adequate concentrations of folic acid in the blood. Now, can you see something here which is dependent upon folic acid? Megaloblastic anemia. So that means phenytoin causes depletion of folic acid. So now translate this folate deficiency into a woman who is pregnant and taking phenytoin.
So it's going to be further down to that.
Spinal bifida. So it is highly teratogenic. Highly teratogenic. So you can't see, you can see in the slides, I have mentioned another slides about the teratogenicity. Yes.
Doctor, so status epilepticus will not stop itself unless you give a drug.
Okay, it's clinician will tell you, let me tell you roughly. What happens, the guidelines are, you write away start for years, 1 year or more than that. Any drug which controls it, and then you look at the seizure free at least 2 months, 2 to 3 months. When there is no seizure for 2 to 3 months, you slowly taper up the dose of the anti-epileptic drugs. That was your question, will it be for lifelong?
No, I mean the status epilepticus, right? You said it doesn't stop itself, right?
No, it will to treat.
You have to like intervene, only then it can stop it.
Yes, that's correct. Okay, so phenytoin is highly teratogenic, and there are various features. The special feature is the spinal bifida, cleft lip, and there are some psychological disorders, mental disorders. These are the. And besides that, I want to show you the figure. Very unique side effect of phenytoin, which is gingival hyperplasia. Not acceptable at all. So this drug is not used except for trigeminal neuralgia for short-term use and as what were the other uses? In status epilepticus for food uses. IV. Drug interactions are many. Phenytoin induces the metabolism of other drugs. If a drug is an enzyme inducer of other drugs, the consequence will be the metabolism of other drugs will be accelerated, rendering those drugs ineffective. Are you with me?
Yes.
So enzyme induction means the metabolism of other drugs is increased. So if it is increased, the plasma concentration of the active drug will become lower down, render the ineffective. You have to increase the dose. Contraindications, bradyarrhythmias, as I mentioned, it causes low heart rate. It is used, can be used as anti-arrhythmic, and obviously pregnancy and lactation cannot. Another drug with similar mechanism of action, carbamazepine, newer drug, but better safety profile. Same indications, same mechanism of action, but better safety profile. So carbamazepine is still used, widely used. Effective in most forms of epilepsy, once again like phenytoin, except absence also. Still, I'm not going to answer later on, I will answer you. Why these two drugs, phenytoin and carbamazepine, are ineffective in absence seizures, only in generalized seizures they are used. Also useful in trigeminal neuralgia and mania. Are you aware of mania? Mania? Craziness. Okay. Opposite to danger, depression. Okay.
Isn't mania like episodes of so much happiness and then sadness?
Yes. So it is, you see, in bipolar disorders, depression
And then mania.
and mania, they come together cyclically. So mania is, I mean, you will hear secondary, not exactly, but opposite. The features are as opposed to depression. Carbamazepine pharmacokinetics absorption is slow and erratic. Half-life is 10 to 30 hours, similar to phenytoin. Many drug interaction. Just keep in mind to make your life easier. Phenytoin and carbamazepine share many features. Mechanism of action, clinical uses, side effect profile, but this is much milder, more effective, but side effects are much less. So in that case, it is better preferred over phenytoin. Okay. Now, phenytoin is absolutely contraindicated in pregnancy. But because of the lower degree of severity of side effects, gerotogenicity, you can still use carbamazepine, but with co-administration of high dose of folic acid. Okay, the third drug is valproic acid or sodium valproate. This is very, very important drug. Widely used. It is broad spectrum. This is a drug which can be used not only generalized convulsions, epilepsy, but also effective in absence seizures. Mechanism of action, look at this first is, it causes the inhibition of GABA transaminase enzyme, which is responsible for the degradation of GABA. With the degradation of GABA, inhibition of the degradation, what will happen? Concentration of GABA will go up. That means indirectly you are potentiation inhibitory neurotransmission, number one. Number two, similar to phenytoin, sodium channel blocker. Number three, reduces T-type calcium channel in the thalamus. And number four, block NMD. So this is four mechanisms, broad spectrum. Among these four, there is one action which is responsible for its effectiveness in absence seizures. Which one? Third one. Because pathophysiological mechanisms underlying absence seizure is the hyperactivity of T-type calcium channels, which are voltage. What do you call T-type? L-type calcium channels, T-type calcium channels, transient. They open transiently and close. And L-type are long-lived. When they open, they persistently open. T is transient. They are in thalamus, and when they open continuously, persistently, that's the pathophysiological mechanism underlying absence seizures. So keep in mind, any drug which inhibits the current in T-type calcium channels in thalamus will be effective in absence seizures. And this one, sodium valproate is one of them. Very effective in absence seizures, partial, almost all. In addition to that, it is mood stabilizer in bipolar disorder as an alternative to lithium. Adverse effects, generally these are acceptable, but teratogenic more than the phenytoin. So absolutely contraindicated. Carbamazepine, if you compare the teratogenicity of three drugs, phenytoin, carbamazepine, and valproate, so carbamazepine is relatively safer. The only thing is you have to be careful by giving okay. By giving the high dose of folic acid to pregnant mother.
What's the issue? What's the issue?
Issue is that it goes blank, the source is not found, neither here nor there. Can I continue?
Yes, you can continue.
Okay. Now, it was succinate. Okay, you give me 5 minutes. I am teaching them. You figure out. It was succinate is a beautiful drug. Very specific in the sense. Now I revise. Phenytoin and carbamazepine, sodium channel blocker, so effective against generalized epilepsy, not against ASMs, seizures. Valproic acid or sodium valproate, broader spectrum, multiple mechanisms, mainly 2 mechanisms, sodium channel blocker, GABA transaminase inhibitors, as well as the T-type calcium channel inhibitors, effective against almost all forms of epilepsy. This one is specifically acting on T-type calcium channels in the cerebus.
So it's only for absence.
Only for essential, drug of choice for essential. It is not effective for other. So ethosuximide is a highly selective T-type calcium channel inhibitor, so only effective in essential. So, and beautiful drug in the sense President Trump always, when he talks about every sentence, a beautiful, modern stuff, beautiful. So in the sense, the beautiful is highly selected and very few minor side effects acceptable. So when you encounter a patient with absence, just give ethosuximide. Calm.
Okay, restart the system, please.
You have to restart?
Yes, yes.
Restart? What do you mean restart?
The PC.
You want to restart the PC?
Yes, because.
Okay, let me see the slides, then I will teach you as it is. Okay, I can teach you without slides.
No, it's okay, doctor. Go as you will, and then we'll do it after the lecture.
Okay. I can teach you.
No, it's okay. Go as you
Okay,
will. It's
okay,
fine.
okay.
Thank you.
Okay, we covered ethosuximide and then benzodiazepines and barbiturates, they were covered by Dana already. Briefly, they are very similar with some very important differences. Barbiturates and benzodiazepines, they bind with their own specific receptors, benzodiazepine receptor and barbiturate receptor. The binding of benzodiazepines with their own receptor, which is in the close vicinity of the GABA receptor. Keep in mind, the barbiturates and benzodiazepines do not occupy the GABA receptor itself. Is that clear? Their receptor, own receptor, lies in the close proximity of the GABA receptor. So the binding of benzodiazepine, so sometimes in the books even, it is wrongly written that benzodiazepines are GABA receptor agonists. No, big no. They are not GABA receptor agonists. They have their own receptors, but binding of benzodiazepines with their own receptor causes a conformational change in the GABA receptor complex that now causes the increase in the interaction between GABA and its receptor. First, benzodiazepines bind with their receptor. As a result of that binding, there is more interaction between GABA and its receptor. And the consequence of that more enhanced interaction is there is increased opening of cannabinoid channels, increased frequency of the cannabinoid channel opening. Whereas in case of barbiturates, it is the same, receptor is different, but there is no increased frequency of the cannabinoid channel opening, but there is increased. What is the difference between barbiturates and benzodiazepines? Cannabinoid channel opening becomes more frequent in case of benzodiazepines, but the duration of cannabinoid channel opening is more in case of barbiturates. One is frequency and other is duration. But ultimate effect is the same. Effect is more hyperpolarization. So more hyperpolarization means the neurons becomes away from excitation. Inhibition, in that case, benzodiazepines. Since benzodiazepines and Barbiturates are highly sedative, hypnotic drugs. You cannot use in the routine practice for the epilepsy. There is only one clinical use of these drugs, which is given intravenously. They are very, very effective to suffer stress in the treatment of status epilepticus. Status epilepticus, where you want to terminate the acute attack of status epileptic. When I touch, it goes away. Okay. And what are the benzodiazepines? Can you name few drugs which can be given intravenously? Diazepam, lorazepam, very good. Two drugs which are preferred for status epilepticus. And barbiturates and IV phenobarbital is preferred. Okay. Now we covered classical, phenytoin, carbamazepine, sodium valproate, barbiturates, ethosuximide, and benzodiazepines. Now let's move to the newer drugs. And out of this, we will only cover mainly two drugs: lamotrigine, broad spectrum anti-epileptic like sodium valproate, blocks sodium as well as calcium channels. Effective in partial, generalized absence, bipolar drugs, everywhere it is effective, lamotrigine, like sodium valproate. And the beauty of this drug is why it is most widely used nowadays, because it is not teratogenic, safer, much safer. Lamotrigine indications like valproate, effective against all forms of epilepsy. Adverse effects are also acceptable: sleepiness, dizziness, diplopia, ataxia. Are you familiar with these terms, diplopia, ataxia? And other drug is levetiracetam. This is another drug, and this is very unique mechanism of action, unique from others. Have you heard about, okay, let's go to the figure first. Okay. Oh, my God. Now, revise the neurotransmission. Okay, here you go. Now, on the left side, there is a normal neurotransmission. What happens? The neurotransmitters are stored in the synaptic vesicles. Okay. What happens when calcium enters presynaptically? There is a rise in intracellular calcium in the neuron. That causes the fusion of those vesicles. Fusion of those vesicles. Then there is a fusion with the neuronal membrane, and neuronal membrane then causes rupture and exocytosis of the neurotransmitter into the synaptic cleft. Now there is one glycoprotein which is known as SVA2. It is localized in two parts. One is its calcium channels presynaptically, and other is on the membrane of the vesicles. So what happens when you target those proteins and inhibit them? There will be two outcomes. One, the calcium rise or calcium entering through the calcium channels presynaptically will be inhibited. There will be no rise in intracellular calcium. There is an stimulus which causes the fusion of vesicles will become number one. Number two, the rupture, fusion and rupture of the vesicle will also be blunted. So overall, neurotransmitter release will be grossly inhibited. It is not inhibited. I mean, most of the drugs, other drugs we discussed up to now, are acting at the ion channels post-synaptically. Post-synaptically, at ion channels, this drug is only one which acts presynaptically by decreasing the release of neurotransmitter. So in this case, levetiracetam is inhibitor of SV2A protein, thereby leading to inhibition of neurotransmission. Adverse effects, once again, like lamotrigine, these side effects are acceptable, and after prolonged periods of use, these side effects are no more troublesome, and you can manage very easily. Okay. Now forget about these drugs. People who are interested, you can. Some are interested drugs actually. Gabapentin was used. Yes.
Can you please repeat how it blocks the calcium channel? The presynaptic
SV A2 is a protein which is attached with channel, and it is responsible for opening the channel. When you block that protein, the channel is not opening. Channel is not opening means intracellular rise of calcium, which happens through the influx of calcium through the channel does not occur. So rise in calcium does not occur. If rise in calcium does not occur, that means that stimulus for the fusion of vesicles is gone. So no more further release of neurotransmitter. Gabapentin is a drug. It was discussed somewhere in this block. Someone discussed it. Must have discussed. Manal. In the context of migraine. Prophylactic. So although it is can be used in seizures, but more than the seizures, it is used in pain, neuropathic pain, and prophylactic use of migraine. Tiagabine similar. Topiramate, once again topiramate similar, she might have used. Did she mention this drug? Gabapentin, prophylactic for migraine. Okay. Felbamate, zonisamide, pregabalin similar neuropathic pain. Now let's move to status epileptics. A patient who comes to you is continuous, without any recovery, non-stop. Benzodiazepines are the drug of choice. IV, not orally. This is emergency. Now let's stepwise go. Stepwise, that is not working. First, IV benzodiazepines and benzodiazepines of choice are either diazepam or rozepam, or you can also use another drug which we mentioned earlier. First drug, phenytoin. Phenytoin IV you can use to terminate status epilepticus. In most of the situations, the seizure will be gone. If it does not go away, then the next step is IV neurodrug. If not, still there are few resistant cases, stubborn, they do not go, then you go for the anesthesia. Anesthesia with midazolam or propofol. Atul might have covered these drugs. Okay. There may be less than 1% of the cases who still do not go away. Then what would you do? Is there any still kind of CNS depression or elevated neurotransmission you can achieve? Beyond that, think. You have covered already. Beyond that, yes. Pardon? What? Say it again. This is general anesthesia. This is not a general anesthesia. Because this is emergency. It's a permanent neuronal damage. It's attack both unabated for extended period of time. You have to terminate that status epilepticus in any cause.
But if they come back from anesthesia, aren't they still going to have?
It may happen, but generally it is rare. It may happen. There is no guarantee the next day it will not come in.
So are
It
we
may come in.
sedating them or are they actually under anesthesia for?
The aim is is, as I mentioned in the earlier slides, because there is excessive neural activity, you have to suppress it with serious depression. You have to initiate inhibitory neurotransmission to such an extent that you have to restore the balance. And this is the most efficacious inhibitory neurotransmission by making the patient completely anesthetized.
So they're not conscious.
No, no, no.
For how long? Because it's status, so if they're not gonna recover, so.
For some few, even for few minutes, enough. Okay, you restore the balance. Yes, ma'am.
So the goal is to get them, to make them stable, like how do you?
To the goal is to terminate the attack of status epilepticus,
But
which
then,
is a highly excitatory activity of the
but then if you give them epilepsy, if you give them anesthesia and then they come back from anesthesia,
there is, yes, it can have, there's no guarantee.
huh?
There's no guarantee. After
Yeah.
the effect of anesthesia is gone, the patient may come dead. But in most of the situation, once that attack is gone, it's okay. In the meantime, what happens, in the meantime, you have already started anti-epileptic drugs. Okay?
Okay, so other epileptic drugs.
Of course. It is not that you right away start from general anesthesia. The guidelines say that you have to start with anti-epileptic drugs. And the maximum you can use 2 doses of benzodiazepines or phenytoin within a span of 10 minutes. If it is not controlled, then you go further. And so step-wise. Epilepsy during pregnancy, let me give you some situations, real situations. You have maintained a woman well under control as far as her seizures are concerned, is carbamazepine. And now she plans the family, she wants to become pregnant. What would you do? Stop.
You would stop it rapidly.
Give high dose of folic acid in case of carbamazepine. If she is taking valproate, stop it. Switch to carbamazepine, better if you are switching, better if she can afford. Because those are expensive drugs, levothyroxine, levothyroxine.
The elbow?
Yes.
Then you will start with elbow. The second. I don't know.
They will sit down. Okay? So you can switch to those or carbamazepine with high doses of folic acid. But valproate is absolutely contraindicated and phenytoin is absolutely contraindicated. Okay. And finally, I have prepared a slide for you. Where there are 3 columns, type of epilepsy, second column first choice and the second choices. Just go through it and see.